and I'll call Dr. Shreyas RAMAMURTHY to talk on optimizing outcomes from SMILE. Maybe just one comment is, in an age-stabilized keratoconus, like the patient is in 30s and the topography is stable, probably, and if he's comfortable with his spectacle vision and does not need contact lenses, these patients we can do phakic IOL without combining it with cross-linking. So on to you, Shreyas.
So I'll be presenting this topic on optimizing outcomes in lenticule extraction, and it is exciting days for lenticule surgery itself, as we now have multiple platforms available. You have the SMILE with the VISUMAX 800, you have SMILE Pro, the Clear from Z8, Elita from Silk, and AIOS from Schwinn. So with all these platforms available, now it also becomes a question of where results are better, where results are faster. What we really need to know is that energy optimization is probably a key word that is necessary in all of these equipment, and therefore I will be concentrating a little bit on energy optimization in the initial part of the talk, and then add a little bit more about centration and docking, and then finally the dissection techniques, which I feel are the three key variables as far as optimizing results in lenticule extraction surgery. So now with the comparison, when you see that the newer machines have a higher repetition rate or a higher frequency, and at the same time, and because of the higher frequency, are able to deliver a lower energy per pulse. So they are smaller pulses with a shorter duration and lower energy. The idea is this will ensure that the cut is a little smoother, and therefore you may have a slightly better interface, because of which you may have a faster visual recovery, lesser tissue damage, and lesser inflammation. One other thing which needs to be noticed is that while VISUMAX and to some extent AIOS has a curved interface, the Zima and the Elita have a flat interface, which causes a higher pressure and flattens the cornea, which results in certain folds which develop in the cornea. The patient also loses fixation. With regard to cyclotorsion compensation, it's automatic in the VISUMAX 800 and the AIOS, whereas in the Elita and Zima and the VISUMAX 500, it has to be done manually. Again, the centration system is automated in the VISUMAX 800 and AIOS, whereas there is a little manual component required in both Zima and Elita. So now when we look at the ideal energy setting, now it varies not just by platform, but also the machine-to-machine variation with each within the same platform. Your OT environment, the optimization of energy for that particular environment, the surgeon in terms of your ease of dissection and the time taken for dissection. It's important to spend time on each of these parameters before reach the balance, because there are multiple parameters which look into how the clinical performance can be affected. And really what we can play around with is really only the pulse energy and perhaps the spot size. Rest, everything else is more or less fixed and for that particular machine that you have. Now why are we talking about this so much? Because when you have excess power, at least in machines which have a venting incision like the Z8, there is an escape of the excessive OBL. But in other equipment, it's only the incisions when they open up that the OBL will escape. So when you see excessive escape of OBL, you know that higher energy has been delivered. If you have a very opaque picture, which I'll show in subsequent videos, that also indicates that this is possibly excessive energy and you need to bring it down. Or sometimes you might find that the cut is very smooth, that the lenticule comes out very easily. And this is something which we have learnt over time, that not every easy extraction of lenticule equals immediately good visual outcomes on day one. Sometimes you may have excess energy which has led to a very clean cut, very easy removal of the lenticule, but this excess energy has led to tissue damage, which makes it a little more difficult. So what you want with an ideal power is minimal gas escape, a very homogeneous cut, and uniform resistance whenever you have. So you want a uniform energy delivery rather than patchy excessive OBL, as you see on the right side picture. Now the energy settings can be varied in almost all instruments, all platforms, and generally we keep a lower power for anterior and a slightly higher power for posterior. And essentially this is because the greater the depth that you are at, and if you are having a higher refractive error to correct, then the power is increased a little bit. In all these equipment, we start off with a higher power and then slowly titrate it down, keep lowering and lowering. In the clear platform, we started it at excessive of 50, but now we are down to the low 30s as far as what is optimal for our machine. But that does not mean that just because it is optimized for our machine, that we are going to have the same number which works well on another platform. This is on the Elita again. We started off again in the high 40s in this, but then we found that it was for the glass burn threshold in our machine was quite low, and therefore I had to even get a special pack for reducing the energy below 40, and at around 35, 36, 37 is when we started seeing different results. So again, the power can be managed for anterior to posterior to the side cuts as well as the ring cuts itself. So appearance of the OBL pattern, adequacy of the dissection or the ease of the dissection, and the day one visual recovery. These are the three clear parameters which helps you recognize whether that energy needs to be further lowered or raised a little bit back to what is optimal energy for your particular machine. Apart from that, you can also have some interface and dark spots. So one is the energy delivered by the machine itself, but the energy taken up at the patient's eye level, it can be also determined because of these factors, like you may have some dark spots or interface debris which has led to an inadequate laser delivery, which is now will lead to a difficult dissection and difficult extraction of the lenticule. The ideal preparation, however, would preferably be applying some saline or BSS just before you dock the patient, wiping around the fornices, not have excess fluid as well, but have a uniform tear film or tear meniscus on the anterior epithelium before you go ahead with the dock. The next important parameter becomes centration. Now, while in some of the equipment you have a curved interface, less pressure at the time of dock, and the patient is continuing to fixate, you could use the fixation light as a target for centration. But whereas when you're doing the equipment which have a flatter dock, the patient loses fixation, and because of the higher pressure, the need for centration becomes very important, because you then end up having a position where the pupil is shifted in relation to the corneal apex. It's essentially because the cornea is pressed into folds, and what we perceived as the center of the pupil to begin with is no longer the center of the pupil, and therefore a manual marking also becomes necessary. There are various instruments described for using manual marking, and this is just one of them which we use. And then once the manual marking is done, once you then take the patient, this is useful for both centration as well as for cyclotorsion compensation. You will see on the AIOS2025 pictures as well, as we dock and we take the patient up, these marks are clearly visible, and then you can rotate the axis and position the lenticule manually according to where your original marks were. And as the AIOS2025 image becomes live, you see that the amount of folds that is there in the posterior cornea. So this is why the centration becomes extremely important on almost all platforms. Cyclotorsion compensation can also be done accordingly, and this is just on the Elita platform. Again, you can see after the dock, once it's locked, you can see that blue mark here. This is the center which has been marked under the using the Purkinje image on the corneal apex, and you then center it on that particular mark of the lenticule. So now you have the centration which is delivered, because decentering these lenticules can itself induce coma and have a suboptimal visual recovery. Quickly on the dissection itself, if I have time, I'll take a minute or so. Yeah. So if you have higher energy, as you can see, this is a completely unedited video. You will notice that the dissection is easy, and you are able to remove the lenticule very easily. So I usually use this, go into the side pocket and come anterior, which makes it very easy. You always seldom have a difficulty. Now you'll see as the spatula goes in, there's hardly any resistance, and it almost seems like the surgery is ideal, that the entire surgery will be over in less than 40 seconds. Now, while the ease of dissection may appear very easy, this patient did not have a good recovery. I in fact went back to the surgery to see what I did wrong, and that's how I took up this for recording. This patient had only a 612 vision on day one. This is essentially because excessive energy was delivered onto the cornea, and this has significantly improved after optimizing energy outcomes. Whereas if you see a patient with a more uniform OBL, you will see that while doing the dissection, there is a little bit more moderate resistance, as you can see in this patient, and the lenticule doesn't come out as easily. But this patient had a 6/6 vision on day 1 recovery. So pretty much 2 laser deliveries on the same platform, but where there is a difference in the outcome is essentially because of the amount of energy delivered even in the same surgeon's hands. In case of excessive OBL, in this case, what really helps is the wedge technique, where essentially you, when you're doing the posterior dissection, you leave behind a small part uncut, complete one side, and then complete the last aspect, so that you continue to have some counter traction and the lenticule does not roll up. This is just, I'll quickly close with this. This is a technique where you can use with the lenticulorhexis or the lenticuloschisis, where essentially we are trying to reduce the amount of manipulation in the tissue. It's not that the time taken itself is saved. So essentially you go along like a rhexis, complete one side, curve to the other side, and then take this around like like you would do for a capsulorhexis, and then complete it and bring it out. The time taken itself may be very similar. It's not really about saving time, but it's the fact that you're distorting the ends a little less. And this may possibly potentially result in less Bowman folds, which itself could have a slightly faster visual recovery, or it could be equivocal. Again, if it is a non-uniform OBL, it may be a little more challenging to do this technique, and you may have to grasp and re-grasp at different levels to avoid tearing the lenticule. It's very important that you ensure that it is done carefully and appropriately, so that if you can always resort back to the normal technique in case this is difficult. But in some of these cases with a very tighter where the OBL has not been very uniform, you may have this difficulty where you have to grasp and re-grasp again and closer to the tearing edge, like you would do with a rhexis which is tending to run off, and then complete the surgery. But then it can be done even in these cases with excessive OBL. But suffice to say that the visual recovery, even with the lenticulorhexis, could be a little lesser if the energy is not optimized. Again, you can use retroillumination to identify any retained lenticules. You could use IVTA for staining. And really, what I would like to conclude with the message is titrating the power with optimal dissection techniques can help in faster visual recovery. Thank you so much.
Thank you so much, Shreyas. I was so specific that optimizing outcomes in SMILE should be dealt in such a way that you take out those salient, difficult issues which is there in all our minds and sort it out. And you did a very great job.